Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 568 of our pharmacotherapy series, which majors in sleep disorders. The first case reads, J.A.J. is a 32-year-old woman who is 16-week pregnant. She is moving into a new home and has been experiencing difficulty falling asleep and staying asleep. She asks whether she can take zolpidem for insomnia like she did before she got pregnant. She also asks whether melatonin or other non-prescription medications are safer. Pregnant women have insomnia symptoms more often than their non-pregnant counterparts, and many ingest hypnotic or sedating medications. Despite frequent usage of hypnotics, healthcare providers are often reluctant to prescribe medications to pregnant women for fear of teratogenicity. Doxylamine is FDA pregnancy category A, though this indication derived from the treatment of hyperemesis gravidarum and not insomnia. Diphenhydramine is in FDA pregnancy category B and is generally considered the safest sleeping medication in pregnancy. Nevertheless, a pregnant woman should only use it on an as-needed basis. Sedating antihistamines are not compatible with breastfeeding as they have the potential to dry up milk supply due to anticholinergic effects. Melatonin, Ramelteon, and suvorexant should not be used because of unknown risks to the fetus. Regarding the most commonly prescribed hypnotic, zolpidem, the American Academy of Pediatrics considers zolpidem compatible with breastfeeding, but the risk versus benefit should be considered on an individual basis. Other Z-hypnotics do not have sufficient data in pregnancy and lactation to make recommendations. Benzodiazepine hypnotics are pregnancy category D or X. They should be avoided in pregnancy due to the risk of respiratory depression, neonatal flaccidity, and feeding difficulties if given in the second and third trimester, and the controversial risk of cleft palate if benzodiazepines are given in the first trimester. Benzodiazepines are not recommended in breastfeeding as the risks outweigh benefits in most cases. The next case reads, TES, a 52-year-old man, presents to an ambulatory care clinic complaining of chronic fatigue, low energy, excessive snoring, and overall less restful sleep. When you ask what prompted TES to come to the clinic, he answers, "My wife and I have been sleeping in separate bedrooms for the last 6 months. She says my loud snoring and gasping to breathe keeps her awake. I'm tired all day and find myself nodding off a lot." His symptoms have worsened during the past year since early retirement. He has gained weight, 6 feet, 220 pounds, body mass index 29.8 kilograms per meter squared, and has developed hypertension. TES's current blood pressure reading is 145 systolic, 92 diastolic. Medications include lisinopril 10 mg and aspirin 81 mg, both taken in the morning. So my next question to you reads: what are the possible causes of TES's sleep disorder, and why is it important for TES to have his problem evaluated in a sleep laboratory? TES reports diminished sleep quality, excessive snoring, gasping for air, and weight gain. Although a number of causes could be responsible for TES's symptoms, one of the most serious is sleep apnea. Obstructive sleep apnea is a neurologic disorder characterized by mini episodes of breathing cessation lasting about 10 seconds. These mini episodes generally occur multiple times in an hour. If there is a reduction in airflow but no cessation of breathing, it is termed hypopnea. The brain responds to episodes of apnea and hypopnea with mini arousals, waking the individual to stimulate breathing. These frequent mini arousals prevent the individual from obtaining quality sleep by not allowing sufficient time in deep, slow wave sleep, or rapid eye movement. Obstructive sleep apnea, the most common type, may be induced when extra body weight, note TES's weight gain, places pressure on the throat and uvula, narrowing the space into which air must travel. This results in the difficulty or cessation of breathing and excessive snoring. An estimated 3% to 7% of men and 2% to 5% of women meet the criteria for obstructive sleep apnea. The apnea-hypopnea index, abbreviated as AHI, measured using polysomnography, i.e., EEG, electrocardiogram, electromyogram, represents the number of episodes per hour. The apnea-hypopnea index score, accompanied by symptoms of excessive daytime sleepiness, is used to diagnose obstructive sleep apnea as follows: greater than 5 to 14 corresponds to mild, 15 to 29 corresponds to moderate, and greater than 30 corresponds to severe. Risk factor for obstructive sleep apnea includes age 65 years and older, obesity, that is a BMI greater than 30, male gender, craniofacial anatomy that alters mechanical and neural properties of the upper airway, genetic predisposition, cigarette smoking, alcohol consumption before sleep, and comorbid conditions such as hypertension, diabetes mellitus, polycystic ovary syndrome, hypothyroidism, and pregnancy. Hypertension and weight gain may be contributing to TES's sleep difficulty. Untreated obstructive sleep apnea is associated with an increased risk of hypertension, coronary artery disease, and cerebrovascular disease. Although sleep apnea occurs in approximately 5% of women and 15% of men in the general population, it occurs in up to 40% of patients with hypertension. Treatment of obstructive sleep apnea can improve blood pressure control and lead to more restful sleep. Of note, obstructive sleep apnea also occurs in non-obese individuals and in all ages, including infants. Sleep-disordered breathing, including snoring, is a significant risk factor for hypertension even in young individuals of normal weight. Overnight evaluation by polysomnography in a sleep laboratory would confirm or rule out sleep apnea and allow distinction between obstructive sleep apnea and the less common central sleep apnea. Central sleep apnea results when breathing repeatedly starts and stops during sleep because the brain does not send proper signals to the muscles that control breathing, i.e., the diaphragm does not move in attempts to take in air. Treatment of central sleep apnea requires continuous positive airway pressure, abbreviated as CPAP. as opposed to being alleviated through weight loss or anatomic manipulations. Central sleep apnea can occur along with obstructive sleep apnea. Results from the sleep laboratory study clearly document TES's sleep problem as obstructive sleep apnea, abbreviated as OSA. He experiences an average of 65 apneic episodes per hour. TES's weight gain and inactivity probably contribute to the problem. Both are serious, potentially life-threatening conditions. The next question reads, why should TES's sleeping difficulties not be treated with a hypnotic medication? Hypnotics, alcohol, or any CNS depressant can be lethal for patients with sleep apnea and should not be prescribed for TES. CNS depressants interfere with the mini-arousals required to stimulate breathing once it has stopped. In this case, the sleep laboratory study may have saved TES from a potential life-threatening breathing disorder that could have been exacerbated by a hypnotic with CNS depressant activity. Obstructive sleep apnea can be treated by tracheostomy, nasal surgery, tonsillectomy, uvulopalato-pharyngoplasty, and either nasally or orally administered continuous positive airway pressure. Continuous positive airway pressure. Weight loss and continuous positive airway pressure therapy are the most effective treatments and must be maintained for continued therapeutic efficacy. In continuous positive airway pressure, the patient wears a lightweight mask to bed each night, and a constant flow of air is provided mechanically to prevent breathing cessation and to allow for more restful sleep. Although continuous positive airway pressure is effective for both obstructive sleep apnea and central sleep apnea, the results are short-lived, and apneic episodes typically reappear when continuous positive airway pressure therapy is stopped. Preliminary studies in individuals with nocturnal bradycardia and sleep apnea show that insertion of a permanent cardiac pacemaker significantly improved bradycardia and sleep apnea. At this time, the best treatment for TES's hypertension and sleep apnea is weight loss and continuous positive airway pressure. The next question reads, if weight loss, surgery, and continuous positive airway pressure, abbreviated as CPAP, are all ineffective or impractical, what drug treatments are potentially effective for TES's sleep apnea? Modafinil and armodafinil agents approved for narcolepsy are also FDA approved to treat EDS caused by obstructive sleep apnea or shift work sleep disorder. For TES, these agents are best used as an adjunct to nightly continuous positive airway pressure usage and morning administration of modafinil 200 to 400 mg or armodafinil 150 to 200 mg. Protriptyline has dated evidence from the 1980s suggesting benefit by improving patients' apnea-hypopnea index, but it is not FDA approved and has only been used in small numbers of patients with sleep apnea. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arora, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video. which will be part 569.